Hello, this is Dr. Fredric Finkelstein from Yale University. It's a pleasure to participate in this meeting. And today I'm going to talk about peritoneal dialysis for the resource limited setting. I'll look into incremental peritoneal dialysis. Let me start by just reviewing for you the International Society of Nephrology's End-Stage Kidney Disease Initiative. And I think we discussed this when we were in Pakistan at the meeting in Lahore, but let me briefly just review the ISN's position on this. The ISN has gotten very interested in understanding and planning for end-stage kidney disease care globally. And in doing so, they've outlined several initiatives. One is to identify chronic kidney disease risk factors to prevent the development of chronic kidney disease. It is estimated that there are 900 to 1.2 million people with chronic kidney disease in the world. And of these, 18 million have end-stage kidney disease. For patients with chronic kidney disease, we want to try to slow progression and prevent complications from developing. For those with end-stage kidney disease, we need to come up with a rational approach to the various options, which include conservative care, dialysis, transplantation, and in terms of dialysis, either hemodialysis or peritoneal dialysis. But only 2.6 million of these 18 million with end-stage kidney disease are actually being treated. Less than 15% of patients with ESKD are being treated globally. But when the ISN looked at what the options were in terms of dialysis management, the sense was that PD is associated with outcomes that are similar to those for hemodialysis, but usually at a significantly lower cost. And for low middle income countries that are contemplating chronic dialysis programs, PD should be prioritized over hemodialysis for its cost saving benefits, and since the outcomes are the same for hemodialysis. Cost issues do need to be addressed, though, and it's important that we place an emphasis on establishing facilities for the local manufacture of PD solutions to reduce the cost, and the training of medical staff to teach patients how to perform PD, and have educational programs to support the advancement of PD in these countries. In a paper that Laura Sola published discussing PD in low middle income countries, this was published in Kidney International in 2020, Laura discusses the advantages of PD over hemodialysis, which is shown in this slide on the left-hand panel. The lower expense, the fewer technical demands, the greater feasibility in remote regions, reduced patient travel requirements, that is, patients don't have to undertake long travel expense and time to get to dialysis facilities. There's improved patient integration into society, since this traveling and moving near dialysis units is not important, and there's a reduced need for trained staff. But there are challenges to establishing PD programs, and that's summarized in the right-hand panel. That is the training of individuals to insert catheters, which can be challenging, the potential risk of infection, which may be higher in lower income countries, the ability to obtain dialysate and catheters in a reliable and fashion at an acceptable cost. It's essential that when people are started on peritoneal dialysis, that there be a reliable source of solutions. You can't have solutions not appearing. Patients will not receive dialysis then. So it's essential that this be established before PD programs are actually set up and running. The practical issues in cost and distribution of supplies need to be addressed. And importantly, there needs to be acceptance by the government and the medical community and patients of the acceptability of peritoneal dialysis. The cost of hemodialysis and PD comparisons are shown here on this slide. PD really should be much less expensive. For example, facility construction for PD is very simple. All you need is a room with some running water and PD supplies. Whereas in hemodialysis, facility construction is elaborate. You need to have water purification systems, hemodialysis machines, electricity, a brisk water supply. For PD, you just need disposable supplies, solutions, catheters, and incremental PD we'll talk about a little bit later. And disposable for hemodialysis, you need these disposables, which are dialyzers, tubing, saline, heparin needles, a much more elaborate sort of set of supplies are necessary. Staffing in PD is much less intense. In most countries, the sense is that one nurse can manage between 20 and 40 patients. And in some places in Asia, they manage larger numbers of patients than that even. In hemodialysis, so the staffing is much more intensive and requires more training, needle placement, facility with machines, for example, other issues like that. Importantly, with peritoneal dialysis, intravenous iron is not really necessary. Iron replacement can usually be done orally. Some patients require IV iron. And erythropoietin use is much less than with hemodialysis because you don't have the problem of ongoing blood loss as you do with hemodialysis. So estimates are that the IV iron and ESA utilization is about 1/3 the cost of hemodialysis with peritoneal dialysis. And importantly, the patient burden is important. That the patient burden in doing PD is simply performing exchanges. With hemodialysis, the patient burden includes traveling to the facility, the cost of travel, the loss of work, difficulty to function because of post-dialysis fatigue, which occurs in the vast majority of patients on hemodialysis. PD patients don't have to travel. They can often continue working, and they don't have the sense of fatigue after the dialysis treatment. But what's important is to control the peritoneal dialysis cost. And to do this, one needs to negotiate costs with the supplier, that is for the solutions to catheters, medications, ensure a reliable source of supplies, understand the goals of therapy, and try to minimize utilization of PD solutions while ensuring adequate dialysis regimen. And that brings us to this question of incremental PD. So before we discuss that, I want to just review that what are the principles and goals of treatment with peritoneal dialysis? One, it's adequate solute removal. Secondly, controlling volume status with ultrafiltration and sodium removal. Importantly, we need to minimize dextrose exposure, and I'll come back to that in a minute. And most importantly, we want to maximize the patient's quality of life. So we want to focus on the patient's experience and the patient's health-related quality of life. And we need to achieve these goals while controlling costs. So how do we control cost and prescribe efficient dialysis? First, we need to target an appropriate dose of dialysis, and I'll come back to that in just a second. Importantly, we want to make sure patients are receiving ACE inhibitors or angiotensin receptor blockers because these drugs have been shown to preserve residual kidney function in patients on dialysis. And in doing so, you can then not put patients on maximal dialysis regimens. I'll discuss that in a minute. You want to use high-dose diuretics to maintain urine volume, and we want to minimize dextrose exposure to preserve the integrity of the peritoneal membrane so it functions on a long-term basis for patients. So let's talk about the adequacy targets now. The old International Society of Peritoneal Dialysis recommendations, which were published in 2006, suggested we should be a minimal KTOV urea of 1.7, which represented the sum of both peritoneal dialysis and residual kidney function. For anuric patients, then, you need to have a peritoneal KTOV of 1.7. Importantly, there was no evidence for improvement in outcomes with higher doses of dialysis, and that was based on the 3 studies shown here, which I'll discuss very briefly in the next few slides. The KTV urea is a measure of the efficiency of the dialysis procedure. K is a modification of the urea clearance, T is the time on dialysis, and V is the volume of distribution of urea, which is distributed in total body water, which we use just rough estimates of 60% of body weight in males and 50% of body weight in females. Obviously, this is not precise, so the KTV really represents an estimate of the efficiency of the dialysis procedure. K is really a measure of the volume times the dialysate plasma ratio of urea. So let me give you an example. If we have a patient receiving 4 2-liter exchanges per day in an anuric 60-kilogram male, now let's assume the patient ultrafiltrates 2 liters. So the volume of dialysate removed then is 10 liters, the 4 2-liter exchanges plus the 2-liter ultrafiltration. And we assume the dialysate plasma ratio of urea is 1 because there will almost be complete equilibration of dialysate with plasma for patients to do 4 or 6 hour exchanges. With the 10 liters of dialysate, that occurs over 1 day. So the time then is 1 day. And V, the volume of distribution of urea, is a 60 kilogram male. It's a male, so it's times 0.6 is 36 liters. The KT of V then is 10 times 1 divided by 36 is 0.28. And remember, that's for 1 day, and KT of V is usually expressed per week. So then you take the 0.28 and multiply by 7, and you get a KT of V urea of 1.96. So that's the way the KT of V is used and calculated. So let's go back and look at the 3 studies that talked about the dose of dialysis. The first is a randomized trial of PD adequacy in Hong Kong, where there were 320 CAPD patients recruited between 1996 and 1999. The initial prescription was 3 2-liter exchanges per day. In Asia, people tend to be smaller, and they can actually achieve adequate dialysis, often with just 3 2-liter exchanges per day, particularly if they have some residual kidney function. They excluded patients with a renal KTV that was greater than 1, so people who had significant residual renal function. And then they broke the patients into 3 groups. KTV of 1.5 to 1.7, Group B had a KTV of 1.7 to 2, and Group C had a KTV level of 2 or greater than 2. And importantly, the dose of dialysis was adjusted by increasing the amount of dialysate that was utilized to maintain the KTV in these targets during the course of the study. And this shows the outcomes of the study, the cumulative survival rates. And importantly, there's no difference in the 3 groups. If your KTV was greater than 2 or less than 1.7, there was no difference in outcome. The difference that was shown was that in the patients with the KTV of less than 1.7, more of those patients were removed from the study because the nephrologist felt the patients clinically were not doing as well as the patients with the higher dose of KTV. So there's no difference in mortality rates, but more patients were withdrawn from the study because people felt they were not doing quite as well. Second study to look at is the ADAMEC study, which was done in Mexico. And this was based on creatinine clearance, but could be stratified by KTV as well. And importantly, these patients were randomized to a higher or a lower dose of peritoneal dialysis. And what you can see when you look at patient survival rates in the upper left-hand panel, there was no difference in survival between the 2 groups. But more importantly, if you look at health-related quality of life, and they looked at the KDQOL for this, there was no difference in health-related quality of life measures. And on the right-hand panel, I show you the results of the PCS score. That's the physical composite score on the SF-36. And you can see there's no difference over time. There's a decline in PCS scores over time, but it was the same decline really in both groups. So a higher dose of dialysis did not improve quality of life, did not improve survival rates in this study. The last study that, and is the only one to show any difference, is a study that was published by Lisa Fried in the American Journal of Kidney Disease in 2008. And that's looked at only at anuric PD patients that were done in DCI dialysis units in the United States and in our program in New Haven. So we looked at 293 patients with a KTV less than 1.7, 366 with a KTV of 1.7 to 2, and 769 with a KTV greater than 2. Importantly, there were no differences in the outcomes of the patient with a KTV of 1.7 to 2 and greater than 2. However, patients with a KTV that was less than 1.7 was associated with an increased mortality rate and an increased hospitalization rate. So again, now in this study, and these are only in anuric patients who don't have residual kidney function, a KTV less than 1.7 was associated with worse outcomes in terms of mortality and hospitalizations. But between 1.7 and greater than 2, 1.7 and 2 and greater than 2, there was no difference in outcomes. Health-related quality of life measures were not looked at in this study. So based on this information, the ISPD revised their guidelines for the adequacy of dialysis. in 2019. And the revised guidelines, I think I would like to summarize here. So first, measures of small solute clearance, KTV, urea, or creatinine clearance can guide the amount of dialysis prescribed, recognizing the limitations of measurement accuracy in individuals. Measuring small solute clearance provides a measure of the amount of dialysis delivered, but there is no specific clearance target that guarantees sufficient dialysis for an individual. Increasing small solute clearance above a KTV of 1.7 may make little or no difference to survival or quality of life. Patients with a KTV less than 1.7 who are otherwise doing well on PD should not have their prescription increased for the sole purpose of meeting that target. Remember, studies showing KTV less than 1.7, it's uncertain whether that's associated with worse outcomes. It was in the Freed study looking at anuric patients, but not in the YK-low study or the ADAMEC study. There's no established minimum small solute target below which PD prescription should be increased, regardless of any other clinical consideration. So measuring KTV urea can be useful in setting up a prescription for a patient. It should be targeted in a range of 1.7 to 2, but simply adjusting the dialysis based on the KTV measurement without taking into account clinical consideration or other factors is not the right way to manage patients. In essence, that's a summary of what these guidelines suggest. But importantly, the revised guidelines emphasize that the presence of residual kidney function at the start of dialysis can enable patients to start on a reduced prescription, which is then increased as residual function declines or as clinically indicated. This can be important in terms of both cost and the patient's quality of life. So for example, if a patient has good residual kidney function, they can start in 2 manual exchanges a day. They can have 1 or 2 days per week with no dialysis. They can have dry days with no fluid in during the day. They can do the exchanges at night or in the evening. Or if patients are on a cycler, they can be in a very simple cycler regimen. Again, taking into account the fact that the residual renal function provides for significant solute clearance. So how do we decide what dose to start somebody on dialysis? I'm going to give you what we do in New Haven when we start people on peritoneal dialysis. First, we collect a 24-hour urine when the patient's in training, and we measure a KTV urea on the residual renal function. We then estimate how much dialysis is needed to provide a KTV of 1.7. This could be 2, 3, or 4 exchanges a day, dialysis 5 or 6 days a week. Patients can have a dry abdomen during all of the day or part of the day. So we discuss this with the patient and come up with a regimen which suits the individual patient needs. But importantly, patients do not need to have 4 exchanges a day or so much fluid if they're on a cycler at night to achieve adequate dialysis because of the significant residual renal function. And this is important in terms of cost saving as well as patient convenience and patient satisfaction. So for example, we have a patient with residual kidney function with a urine volume of 1.5 liters with a urine urea concentration of 240 milligrams per deciliter and a blood urea of 50 milligrams per deciliter in a 70 kilogram man. The K is the urine volume, again, times the dialysis plasma ratio, which is 1.5 liters times 240 milligrams per deciliter. The urinary concentration divided by 50 is 7.2. And this is times 1 day, again, it's for a single day, times 0.6, it's a male, times the body weight of 70 kilograms. That's the volume of distribution of urea. And that's 0.17, and that's for 1 day. So you multiply by 7, and that's 1.2. So 7.2 then, I'm sorry, so that's a KTV of 1.2 over here. So now the question is, if the patient is started on peritoneal dialysis, we need to give them sufficient dialysis to get the KTV up to 1.7, which would provide adequate dialysis. So for example, the patient get 2 exchanges of 2 liters and say they drain 2,250 cc's per bag. That's 4,500 cc's total drainage. With a long dwell, there'll be complete equilibration of urea. So we assume the dialysate plasma ratio is 1. So it's 4.5 liters times 70 times 0.6 again is 0.11 times 7 is 0.77. From the dialysate, we're estimating what the clearance would be. So the total KTV then is 0.77 from the dialysate, 1.2 from residual kidney function, and the KTV is 1.9. So importantly, this patient can achieve adequate dialysis with just 2 exchanges per day. And this makes the convenience for the patient very nice, and it certainly reduces the cost of dialysis. What's important then is to monitor the residual kidney function over time and adjust the dialysis as clinically indicated by the patient or as indicated by changes in laboratory findings. So that's the principle of incremental PD. And again, it requires ongoing assessment of the level of residual kidney function, ongoing clinical assessment of the patient, monitoring of laboratory data, and then adjustments in dialysis regimen as clinically indicated. But in doing this, we need to focus on a couple of the key issues. One is to preserve residual kidney function and control volume status and ultrafiltration and sodium removal. Those are critically important. And at the same time, we need to minimize dextrose exposure because this is important in preserving the peritoneal membrane over time. So I just want to talk about this briefly now because this is important in our understanding the concept of incremental PD. So again, we want to preserve residual kidney function, maintain or increase urine volume. So we have to minimize the amount of ultrafiltration which is necessary to reduce exchanges, cost saving, reduce the burden on the patient, and use less hypertonic exchanges, which will again expose the peritoneal membrane to high glucose concentrations. So several studies have shown that residual kidney function is preserved by either ACE or ARB use. And I'm just going to show you a couple of these. This was a study that was done in Hong Kong many years ago, where it looks at the probability of anuria on the y-axis and the follow-up in time over 12 months over here. Patients were randomized to ramipril, which is shown in the circles, and the control group in the squares. And over the 12-month period of time, significantly more patients in the control group became anuric than those of ramipril group. Another study done in Japan looked at residual kidney function and ARB use, and this looked at the urine volume, again, over a 24-month period of time. Patients receiving the angiotensin receptor blocker, which is shown in the white bars, had a significantly higher urine volume than the control group. Urine volume can be well maintained with diuretics. This is a study that was done from the United States, looking at patients from the UK, receiving 250 milligrams of furosemide and patients receiving no diuretics, and the urine volume was significantly higher in those patients receiving furosemide, so that even in patients with end-stage kidney disease, high-dose diuretics can result in significant increases in urine volume and a reduced need for ultrafiltration to maintain adequate fluid balance in these patients. And importantly, it's well established now that the peritoneal membrane changes over time. And this occurs because of inflammatory markers which occur in the peritoneal cavity, resulting in thickening of the peritoneal membrane, as shown here. This is a baseline peritoneal membrane at the start of dialysis, and this is what it is like after patients have been on PD for a long time. So you get thickening of the peritoneal membrane, hypertrophy of lymphatics, increased vascularity, which results in increasing rates of solute transport. So this is a study from Simon Davies in 1998 showing that over time, there's an increase in dialysate plasma creatinine ratios with the standardized PET test. And this occurs because of the changes in the peritoneal membrane, the lymphatic hypertrophy, and the increased vascularity that occurs over time. And the standard teaching now is that these changes in the peritoneal membrane occur because of glucose exposure, because of formation of AGEs inside the peritoneal space, which results from heat sterilization and glucose degradation products. And the glucose, again, forming AGEs, which then bind to the receptors for AGEs and stimulate a variety of inflammatory cytokines in the peritoneal membrane. And importantly, these receptors are expressed in the peritoneal membrane, and this again binds with the AGEs, which form and stimulates inflammation in the peritoneal membrane. And that's the standard teaching, for which there's a lot of experimental evidence to support this. And in this classic paper, again by Simon Davies, published in Kidney International in 1998, again, this shows the increasing dialysate plasma ratio of creatinine over time. But importantly, when Dr. Davies looked at this in relation to glucose exposure, he broke them down into two groups of patients, those patients who had a high glucose exposure, which is shown in blue, and those who had a low glucose exposure over here. You can see that the glucose exposure increases in time in the patients receiving the higher amounts of glucose, but the transport characteristics occur at year 3. So the change in the peritoneal transport characteristics occur in those patients who had a high glucose exposure, which is the one shown in blue, suggesting that is the high glucose exposure that then contributes to this change in peritoneal transport characteristics. So what do we do then with patients when they're starting on peritoneal dialysis? We want to use ACE or ARB therapy in virtually all patients, independent of blood pressure or the cardiac effects of this medication, because this preserves residual kidney function. Secondly, we want to use high-dose diuretics in almost all patients to increase urine output. And this involves using high-dose diuretics up to 240 or 480 milligrams of furosemide or 8 to 10 milligrams of bumetanide. And by using these drugs, you can minimize the amount of dialysate which is necessary, minimize the use of hypertonic exchanges, preserve the peritoneal membrane. And critically important is dietary salt restriction, because this again minimizes the need for ultrafiltration, the use of high glucose containing solutions. But lastly, we can't lose sight of the fact that probably the main goal of what we want to do with our patients is to maximize patients' quality of life. We want to focus on the patient's experience and the patient's health-related quality of life. So let me just go back and just again review what our goals of care are. We want to maximize patients' quality of life. We want to reduce the patient's symptom burden. This requires an ongoing assessment of individual patients' health-related quality of life and patient goals of care. Requires an ongoing dialogue with the patient and the dialysis team. We want to adjust the dialysis regimen to achieve these goals. And remember that the advantages of PD over HD involve the impact of the treatment of the patient's life, not because we get better outcomes. But in doing this, we want to focus on minimizing the amount of dialysis which is necessary, minimizing the dextrose exposure, maximize residual kidney function, maximizing urine output. This will be good for the patient's quality of life, reduce the cost, and enable us to offer dialysis to a large number of patients. But before I conclude, there's one caveat that I want to mention. We need to think about what the long-term outcomes are of peritoneal dialysis. And this is important as we plan dialysis programs, particularly as we expand PD in low-resource countries. So this is a little bit of a complicated slide from a few years ago in 2016, looking at the ERA EDT registry over a 20-year period of time. And basically, the results have been very similar over time, but let me show you what we're really looking at here. So these are patients who start on peritoneal dialysis over time. And here we start with, let's say, all the patients starting on peritoneal dialysis. So the number of patients remain on PD decreases over time. So over 5 years, 27% of the patients are going to die. About 30% will be transplanted. 33% change to hemodialysis because of complications of peritoneal dialysis, and only 9% of patients remain on peritoneal dialysis. So we want to encourage transplantation. We want to minimize death rates, and we want to minimize the transfers to hemodialysis. But these have remained relatively constant from 1993 to 97 period to 2003 and 2007 here. Transfers to hemodialysis happen because of infections, because of complications, because of loss of ultrafiltration. They happen over time. This is critically important. So as we expand PD programs, we need to have adequate hemodialysis backup for the patients who do not have acceptable outcomes on peritoneal dialysis. It's not to say we shouldn't expand PD programs. We should. We should do this, focus on this in low-resource countries to reduce cost. But we need to provide adequate hemodialysis backup to support the patients if they do not have clinically acceptable results on peritoneal dialysis. Thank you very much, and I'm happy to take any questions.